Today on Primary Care, we're coming to you from Plymouth United Church of Christ in Detroit, where I sit down with Dr. Versha Pleasant to talk about Black women and breast cancer.
If there's one thing that listeners take away from this segment, please, please know your family cancer history. It could save your life. It could save a loved one's life.
Hello, I'm Dr. Lonnie and welcome to Primary Care, the show dedicated to improving the health of African Americans. For decades, lung cancer has been the leading cause of death from cancer for both Black and white men and women. But as of 2019, breast cancer has become the leading cause of cancer death for Black women. According to the American Cancer Society, Black women with breast cancer are more likely to be diagnosed with advanced stages of the disease, which is usually more costly and difficult to treat. They are more likely to have delays in treatment and are less likely to receive treatment that is recommended. Here to talk to us about why Black women receive late breast cancer diagnosis and treatment is our guest, Dr. Versha Pleasant. Dr. Pleasant is a clinical assistant professor in the Department of Obstetrics and Gynecology at the University of Michigan. Dr. Pleasant's work focuses on cancer prevention and early detection. We're fortunate to have her with us today. Dr. Pleasant, thank you so much for joining us.
Nice to meet you, Dr. Joe. Thank you for having me.
Good. It's long overdue, I hear, for you to get on this program to keep us updated on where we're at in the treatment of Black cancer, especially as it relates to the African American community and Black women. Have we made progress to the degree that we can say we've got this wheel turning, it's headed in the right direction, we're getting this message out? What is our status right now?
I think we've made some headway, but we still have a long way to go. Breast cancer is a huge problem in the United States. The prevalence of breast cancer in the United States is 12%, so 1 in 8 women will be diagnosed with breast cancer in their lifetime. That is a startling statistic. That means that every 2 minutes, a woman is diagnosed with breast cancer, right? So even though the data suggests now that the incidence rate of breast cancer is starting to become equivalent between the Black community and the white community, the data still suggests that Black women are more likely to die from breast cancer. They have a 40% increased mortality. So we still have a lot of work to do in this area.
Is that gap beginning to show some improvement?
I still think that we have a way to go. And part of the reason for that is just what you had mentioned earlier. Black women are more likely to have delays in diagnosis. One particular study showing that the time from abnormal mammogram to biopsy for Black women was about 29 days compared to 20 days in white women.
You mean just getting through the process and once diagnosis is made?
Just getting to the process of getting a tissue diagnosis correct. And another study showing that 1 in 7 Black women were likely to undergo delays in the initiation of care. We're talking about 60 days or more. These, again, are statistics that we need to change.
So we're actually discussing numbers that say that people are waiting for whatever the reason, 2 months, just getting to their first course of treatment for breast cancer?
Correct. And the data suggests that this could be due to a lot of different reasons. There is a lack of information in the Black community regarding breast cancer. Sometimes there are feelings of mistrust regarding medical care, which is sort of a larger issue. Sometimes there is misinformation or fear regarding breast cancer. These could all be barriers to care. Some other studies cite that logistics could be barriers to care, things like transportation, access to healthcare, caregiving responsibilities, right, that exist in our community. All of those could pose barriers.
Talk about risk factors.
Yeah, so cancer is really, really complex. So I just want to start by saying that breast cancer is not necessarily due to one particular risk factors, but potentially a culmination of multiple risk factors. One of the strongest risk factors being a family history of breast cancer. So first-degree relatives, second-degree relatives that have had breast cancer. Another risk factor is known genetic mutations that increase the risk of breast cancer and other cancers. BRCA or BRCA is one that people have commonly heard of that can increase risk of breast cancer. Other things that can increase risk of breast cancer, having dense breasts, starting periods earlier in life, like less than 12 years old, undergoing menopause at a later age, like 55 or over, patients that have had chest wall radiation. We don't talk about that often, but there are some patients that have had a history of cancer in their childhood, early adolescence that have had radiation to the chest wall. That can increase future risk of breast cancer.
Yeah, just saw a patient recently like that who had a thymus problem, who underwent the same thing.
So those are just some of the risk factors. Other things that could contribute, things like obesity, excessive alcohol use, sort of things that we can modify potentially in lifestyle that can impact the risk.
What about warning signs? I mean, a lot of times we're discussing these things with patients, and we're inundated with commercials on television in terms of patient education, and hopefully they're listening. Talk to us about warning signs that women and husbands, significant others, should be looking for in terms of breast cancer.
Absolutely. So there are breast cancers that can present without symptoms. And this is why screening mammograms are so incredibly important. Absolutely. Because they can detect things that we don't see, feel, etc. But there are some breast cancers that can present with things like a palpable lump, changes to the skin of the breast tissue, nipple discharge, pain. So these are things that patients should watch out for and should touch base with their primary care physician if they notice these.
And most importantly, that annual mammogram.
Correct. Really, really important. Very important that women start getting mammograms at age 40 and that they get them every year. Since
you touched on that, should we be listening to the controversy in this country in terms of when they should have it? I mean, patients show up all the time and say, I was told I only needed my mammogram every other year. And we're saying, nope, that's not the case. Or I don't need to start at age 40. I can go to 45. I mean, touch on that for us because, we have to clear up the conversation and the confusion about this.
Absolutely. Breast cancer is way too common in this country to play around with. That's my opinion. 1 in 8 will be diagnosed with breast cancer in their lifetime. So I'm also a little biased because I run a clinic in which I only see high-risk patients. But mammograms work. They save lives. Depending on what source you read, if you're looking at American Cancer Society, if you're looking at the U.S. Preventive Services Task Force, if you're looking at National Comprehensive Cancer Network, or the American College of Obstetrics and Gynecology, ACOG, you're going to hear vastly different things. But I generally like to go with sort of a combination of the NCCN and ACOG guidelines, which state that women should start getting mammograms at age 40. They should get them every year.
Are we running into barriers in terms of affordability and insurance? I thought we had jumped that hurdle with, mammogram on demand and, all insurances being mandated. I mean, are we still having issues with that?
Most insurance companies, from what I've been observing, most insurance companies are covering mammograms because they've become a part of routine care. So for women 40 years old and greater, that should not be a problem.
Okay. We see a lot of reports that come back from mammograms, especially on the primary care end, talking about dense breasts, and that seems to be a factor in African American women also.
Absolutely. So dense breast tissue, there's a lot of myths regarding dense breast tissue and a lot of fear regarding dense breast tissue. So let's unpack that right now. Patients can have different types of breast densities, and the way we diagnose that is actually by doing a mammogram. Dense breasts carry an inherently increased risk of cancer, and that's due to 2 different reasons. One, dense breast tissue is an independent risk factor for breast cancer, so inherently it just increases the risk of breast cancer for maybe various reasons that we don't fully understand at this point in time. But another reason why it increases risk of breast cancer is because a tumor or a mass or calcifications on mammogram can show up as bright white. Dense breast tissue also shows up as bright white. So imagine trying to decipher a white object on a white background. It makes it more challenging, and that's why it's harder to diagnose breast cancers with dense breast tissue.
Are there any environmental factors, dietary factors that contribute to the development of dense breasts?
This is still an area of research. Some people think that potentially dense breast tissue is something that's inherited. Some people think that it could be related to a history of hormonal therapy or someone's weight or their age. There's a couple of different factors that could potentially impact that, but it's still an area of research.
The point is that when you find dense breasts, it's a red flag.
Yeah, dense breast tissue is just knowing that you have an increased risk of breast cancer. But unfortunately, at this point in time, we don't have any national guidelines that inform any additional screening other than a mammogram. Radiologists have to inform patients, and PCPs have to inform patients that they have dense breasts. But at this point in time, nothing additional other than the screening mammograms.
A lot of the things we've been discussing here are about patient education, but there's also physician education that has to take place in tandem sometimes. How are we progressing? Are we getting the word out, not just to the community at large, but I mean, one-on-one with patients? Are the physicians, as a whole, as a cohort, are they actually buying into stepping up to this whole thing of spreading this message? Because a lot of people, if they don't hear from the doctor, they're not hearing it at all.
That's correct, and that's a really good point, Dr. Joe. So I think the understanding of how profound breast cancer is in this country, that understanding exists among health professionals. I think the discrepancy here, though, is that while we understand that 1 in 8 women will be diagnosed with breast cancer in their lifetime, we often don't appreciate that Black women have a 40% increased chance of dying from breast cancer compared to their white counterparts. That's a really big deal. That means that screening mammograms become so much more important for Black women. That means that genetic testing offers so much more promise for the Black community. So that's an area that I think can't be stressed enough. And I think in addition to that, creating more outlets for primary care providers, for OBGYNs, to better understand genetic testing, right? This is a field that's rapidly evolving, and we need more education among this group because these are the physicians that open the door to genetic counseling and testing for patients. So we have to educate them about testing criteria, which patients are at increased risk, so they can be identified and they can be referred to care.
Talk to us a little bit about the extent of genetic testing. What other areas can it be useful in?
If we're talking about Black women having an increased risk of dying from breast cancer, having more aggressive subtypes of breast cancer, being diagnosed at younger ages, then prevention plays a really critical role in this population. This is where genetic testing can come in, right? We can do the genetic testing, which can potentially identify harmful mutations that increase risk of cancer, and we can identify these patients before they even develop a cancer. The way it works is that a patient meets with a genetic counselor, talks about their family history and their personal risk factors, and then provide, if they decide to move forward with the testing, they provide consent. Nowadays, instead of a blood draw, we're using saliva samples. So once you submit a saliva sample, a couple of weeks later, you have your results, you meet with the genetic counselor again, and you talk about those results. Let's say a patient discovers they have a harmful mutation, like let's say, for instance, BRCA, okay? Then this could totally revolutionize the way that they undergo medical care. We have intensive surveillance where we're doing more breast screening to catch a breast cancer early. We have medications that we can give patients to decrease their future risk of breast cancer. We potentially have surgeries that we can offer patients to decrease their risk of cancer. And not even just breast cancer, we're talking about other cancers as well. So this is really, really important. And if a patient does have a harmful mutation, then we initiate what we call cascade testing, where other family members get tested. We could save the lives of so many people through this whole process. Another thing that I want to point out, Dr. Joe, is even if a patient has a negative genetic testing result, the assessment doesn't stop there. A lot of genetic counselors are doing calculations called lifetime risk assessments. That's using different risk calculators to estimate what a person's lifetime risk of breast cancer may be. And if we find out that that's elevated, a patient may actually be eligible for more screening other than just a mammogram, say, for instance, an MRI or more frequent clinical breast exams in the doctor's office. So this is why I really stress to patients, it is important, if you feel like you're at risk, it's important to see a genetic counselor and have all of these things assessed.
On the internal medicine side, we're in the process of looking at or even developing a list of drugs just based on saliva DNA testing, genetic testing that says this one's better for you than that one, and it's all based on a saliva test. I mean, it's going to be it's here. It's here. We're just finding ways to incorporate it more than what we do. Versa, a lot of the newer drugs that we're using, even the drugs that are in research, a lot of them are finding their basis for existence even and development is being based on genetic testing. We're seeing here that that's creeping into, and not at a faster rate. I've had genetic testing as a patient. It's creeping into what we do in terms of making plans for patients in the future in terms of treatment and prevention. Talk to us about where that's going with breast cancer.
Absolutely. The first thing I want to mention is that a lot of people hear about BRCA or BRCA1 and 2. That's probably one of the most popular breast cancer related genes that we know and hear about. But I want to bring to everyone's attention that there are a host of other genes that we've discovered in the past 10 years that increase the risk of breast cancer, ovarian cancer, and other cancers that we don't hear as much about. PALB2, CHEK2, ATM, TP53, right? These are ones we don't talk about, but they exist. And the exciting thing about genetic testing now, it's not just exclusively BRCA1 and 2. It's what we call expanded panel testing, where we include all of these other genes that aren't really talked about, but that can increase risk of cancer. The other thing that I'd like to mention too is that there's a national conversation going on right now as to whether all people that have been diagnosed with breast cancer should undergo genetic testing. That's currently not the case. You have to meet certain criteria based on personal or family history. But I'm really curious to see where this conversation is going to go, because that could really change the landscape of how we talk about breast cancer and prevention.
With some of our efforts here in the Detroit area, we've done a fairly decent job of having the lay public talk about certain things, and one of them is triple negative breast cancer. Is there a role, or what is the role for genetic testing in triple negative? Now, we know you're below the cutoff in the guideline. It occurs early, but obviously there's going to be a genetic basis for this also in that disease.
Absolutely. And something that has changed over the past few years is that the National Comprehensive Cancer Network has now included triple negative breast cancer in some of its testing criteria. So now any person that's had a triple negative breast cancer, irregardless of age, should have genetic testing. And it's because that's a more aggressive cancer, right? That's a cancer that we see in conjunction with, say, BRCA1. So it's really, really important for patients to really reflect on genetic testing and their eligibility for that.
Unfortunately, we've all been afflicted with this disease one way or another. Not from a physician standpoint of view, but from a personal standpoint of view. You know somebody in the family, a different relative, a neighbor, somebody at church. I mean, you're affected by this in one way or another. That's why the education is so important in terms of how we get this message out to people. If we're ever going to stem the tide of any of these disease states, we've got to be focusing on, or refocusing, or retreading on how we deal with patient education. University of Michigan is great in that regard, like a lot of other institutions. But here again, University of Michigan has extended itself in various ways to help us try to educate in this regard. And we know that in breast cancer that is the case. What kinds of programs are available there currently that the public should be aware of for breast cancer education?
One of the most important things that we do is education. Okay, we have a really, really robust community public health and prevention program at the Rogel Cancer Center at University of Michigan. And one of the things that we did, so for instance, last year we hosted a webinar for the community talking about family cancer history. Okay, and so we scheduled this webinar shortly before the holidays, the Christmas holidays. And the reason why this is important is because I like to use this time of the year to encourage patients. Use that opportunity of the holidays when you're sitting around with your entire family. Talk about family cancer history. If there's one thing that listeners take away from this segment, please, please know your family cancer history. It could save your life. It could save a loved one's life, right? This is the time to talk about it. Hey, that gynecologic cancer that grandma had, was that uterine cancer or was it ovarian cancer? Those are two very different cancers. Auntie had breast cancer. How old was she when she was diagnosed? Unfortunately, there is a culture in some families of silence and of superstition, right? That if we talk about death and cancer, that somehow brings about bad luck. But I want to reframe the way that we think about this, okay? Sharing family cancer history is an act of love. Sharing information is empowering your family members to take charge of their health. So we really put an emphasis on family cancer history and getting that message out so that we can get people connected to genetic counseling.
That's a very important point. I ran across something published somewhere a couple months ago, how when we go in a primary care setting, when we go through the phases of interviewing patients and we talk about family history, that's one of the shortest areas that is so deficient because we have not had those stories being told around the dinner table. And I think it's a perfect idea when you're talking about the holiday time where people are gathering and stuff, and other times of the year where we actually begin to talk about this. If we don't have the discussion, the data does not come out, whether it's research or the dinner table in terms of what happened. You'll hear people say, well, my grandmother had cancer, but I don't know what kind. It might have, that is so inefficient in terms of us being succinct and more detailed about gathering that information. I think that's a perfect point in terms of how we reframe, readdress, because it brings me to my next question. We got a lot of taboos in this community about medicine in general and breast cancer in particular. What kind of barriers do you see that occur on a recurring basis in terms of patients having hiccups when it comes to this discussion and, oh, this happened to my aunt, or, they did this and they had this outcome? How do we dispel a lot of these myths that we still have to deal with in this disease?
Exactly. I think silence is the first one that we have to work on as a community, right? We don't talk about family cancer history as much as we should. And as I mentioned before, sometimes there's a global term of like a pelvic cancer or a gynecologic cancer. Really important to know if that was ovarian cancer, right? Because ovarian cancers, and when we talk about genetics, like to travel with breast cancers, right? It's important to know what age people were diagnosed with cancer. So I often tell people that when you're collecting a family cancer history, write down the person and how they are related to you, what side of the family they're on, what their cancer diagnosis was, and the age of diagnosis. Are they still living? What age did they pass, if not, right? Cancers like breast, ovarian, uterine, pancreatic cancer, prostate cancer, colon cancer. And we're not just talking about mom's side of the family. This is a really important point I want to make. Patients often will only report to me that mom had breast cancer and mom's mom had breast cancer. And I say, well, what about dad's side? And they say, oh, well, that doesn't really matter. It does. We get half of our genes from mom and half of our genes from dad. So I equally want to know about your paternal lineage. That is just as important. Another thing I want to point out is some red flags. So as you're taking a family history, what should you look for? Multiple breast cancers in the family on both sides, but particularly on one side, ovarian cancer, pancreatic cancer, male breast cancer. Yes, men can get breast cancer. That's correct. And then early onset breast cancers that are diagnosed at the age of 45 or younger. These are red flags, and if any of these things pop up in your family history, you should seek care with a genetic counselor.
Versha, we're sitting here at Plymouth Church here in Detroit, the United Church of Christ in Detroit. We're on our church circuit, so to speak, in terms of the community spread. What do you see as the role of the church in a community, something like this, in terms of breast cancer awareness and breast cancer education?
The church has a critical role to play in breast cancer awareness, and in fact, they are doing just that. Not all patients get their health information from a doctor. Not all patients trust health information from a doctor. And not all people receive medical care within the four walls of a hospital. We have to acknowledge that. There's so much opportunity in leveraging community-based organizations, faith-based organizations to reach communities with this really important information that disproportionately impacts them in an environment that is safe, in an environment that they trust, sometimes from a person that looks like them, right? And maybe experiencing the same sort of risk that they're experiencing. I think that the Black church plays a critical role, and the Black church globally, I feel, has done a lot in terms of breast cancer awareness, both here in Detroit and in other parts of the country.
Right, other parts of the world. As a matter of fact, I hate to say it, some people are doing it better than we are, but that's something for us to catch up to. How are we doing in terms of treatment?
In terms of treatment, so there are four major components of breast cancer treatment. There is surgery, chemotherapy, radiation, and what we call endocrine therapy if patients have a hormone receptor positive breast cancer. So we've come a long way with treatments, and we're at a point now in history where if we catch breast cancers early enough, say through a screening mammogram, then we have a really, really good probability that we're able to address and treat that cancer. Now, I also say that with the caveat of it depends on the type of cancer, right? When we're dealing with triple negative cancers, those are harder to treat. High grade cancers, things like when people have delays to treatment and then they present with a later stage of cancer, that poses more challenges. But with those 4 tools in our tool belt, those are the ways that we can address and treat cancer. And not every patient needs to get all of those things. And the reason why I bring that up is because for some Black women, there might be fear of screening mammograms, because then if you get a screening mammogram, there may be a diagnosis. And if there's a diagnosis, I don't want to have chemo. And I've heard a lot of patients just so terrified of chemotherapy, for instance. But not all patients get chemotherapy, right? It really depends on the type of cancer you have, on the cancer profile.
That's correct. Not to mention, here again, we always seem to look at the basis for a lot of this progress that we make in terms of treatment is patient education. There's so many people who suffer from myths about what is and what isn't, especially when they try to do it on a comparative basis. What happened to somebody else may happen to me. We see this in all phases of medicine. However, we are light years ahead of where we used to be in terms of especially diagnosis, but also in treatment. And patients need to begin to understand that this is, not necessarily the way it used to be. As a matter of fact, it's not the way it used to be. We have success stories. We have not only success stories, we have success statistics that talk to us and help us understand the next phases of what we need to do to continue to make progress. But we still have the basis of all of this is a patient education in terms of getting them to understand where we're at and what we recommend. A lot of times, I think that we're not really, maybe God gave us 2 ears. Maybe people are listening, but they're not hearing us sometimes. And retreading the conversation, I find to be very helpful sometimes to say, listen, let's start over again. Let's go back to where we are. It doesn't take as long as it did the initial explanation or encounter, but it really helps people rethink the process and buying into not the disease and having the disease, but buying into the recommendations, what the treatment is, and thankful for people like you who have that ability to be so successful in helping us take care of these patients. Versha, this has been outstanding. We love having you on the show, and thank you for all that you do in this arena. Treatment and detection of breast cancer. Thank you so much.
Thank you so much, Dr. Joe. It's my pleasure.
Good.
Thank you.
Our guest has been Dr. Versha Pleasant, Clinical Assistant Professor in the Department of Obstetrics and Gynecology at the University of Michigan. Early detection is the best protection against breast cancer. It's important to know your cancer risk and to be proactive about your health. Thank you for watching. For Primary Care, I'm Dr. Lonnie Joe.